Science program, work very closely with Doris and members of our team who are also on the line. And just really excited to kind of close this year off with, this is our webinar topic. So it is continuing the conversation that we started last time, really about mobilizing collective action for long-term care reform in Canada. And this is part of our health system transformation and COVID-19 webinar series. So we'll continue in the new year in January. What's new in January is these will be Monday afternoon, not Monday evening. So those will be, that's the time change for that. So I would like to hand things over to you, Doris, to give an overview of the webinar, and then hand it again over to André, and I'll advance the slides.
Thank you so very much. And as we speak, we surpassed the 100 attendees, and we have close to 500 registered. So we will see how many of those 500 make the time between the Hanukkah candle lights, the Christmas preparations, and any other holiday that they're preparing or rest that they need to take. So I want to take a second just to recognize all of those of you that are attending. We do know that people are pretty exhausted and tired. And for you to take time, whether you are a family member of a resident or a staff, or someone from the media, or another person that simply cares about the care and well-being of residents in nursing homes and the staff that take care of them and their families that lose sleep at night. So thank you for spending the time with us. I want to remind us that we are 10 months into this pandemic, a pandemic that takes not a second to rest, not a second to sleep, and not a second to celebrate holidays or to take weekends off. And I say this because as much as we all are getting very excited with the vaccine and the fact that today they started the vaccination here in Ontario and is moving to other parts of the country, let's remember that it will be months and months until actually we will achieve a large number of the population being vaccinated. And this is important because we need to remain focused and not completely change the channel, as we say, to the vaccination without looking at the here and now and all those important public health practices that are so important. And John Tory was today pretty strong about that and pretty upset and furious about what was happening in the weekend, not by the majority of Ontarians, but by some that put the rest really at risk. And at risk, you will see in the statistics and numbers from Nathan Stoll, and you will hear also from Carole Estabrooks, and then from all of us in terms of comments, and from the Family Council, Wendy Francis, that will bring also that perspective, and then from people that work on the ground as it is with my colleague Morgan Offord. So with that, I want to hand it to André Picard, and at the end, André, let's remind people again to stay focused on suffocating this virus, vaccine and public health measures before things get even more difficult than what they already are. So André Picard, first of all, a big thank to you for joining us for the second time, and also for the upcoming book that you have. If you will take, as you introduce us to the topic, a couple of minutes to share about your book. Last time you were very humble, as always you are, and we do want to hear about the book, if you don't mind, André. Thank you.
You're on mute.
Print reporters aren't good at TV. That's why we remained on mute, but I'll try talking now with my mic on. So I was thanking Doris, for mentioning this is a historic day. Pandemic vaccination programs began this morning in both Canada and the US. The first people vaccinated were personal support workers, nurses, and elders, the groups at highest risk in this country and around the world. But as exciting as that is, the pandemic is far from over. It's going to take a long time to do these vaccinations. To date, more than 73 million people have been infected around the world, and at least 1.6 million have died. Canada, of course, hasn't been spared from this pandemic. We're very close to 470,000 cases now, almost 500,000, more than 13,500 deaths. And those numbers are growing, and they're growing more quickly. At a rate of about 6,000 new cases a day and 100 deaths a day in Canada now. Pretty grim numbers for the holiday season, and sadly they're getting worse. Now, what distinguishes Canada from a lot of the rest of the world is the large majority of our deaths have occurred among our elders, particularly those in institutional care like long-term care homes, nursing homes, retirement homes. And that's why we're here tonight, to talk about that very important issue. We're also seeing a repeat of the deaths that happened during the first wave, during the second wave. It's as if we haven't learned too much, or certainly not enough, and we'll talk about that. Now, this carnage has also shone this bright spotlight on the inadequacies of elder care in this country. We have gaping holes in our social safety net, a Medicare system that largely abandons you outside hospital, ageist public policies that are commonplace, and all these things that Doris very kindly mentioned. I've written a book that's coming out soon that tackles some of and many of these issues in much greater detail. But I'm not here tonight to plug the book. I'm here to talk about the current issue and to listen to the experts. You know, so much attention has focused on this disaster that we should use it as an opportunity to fix elder care, both the nursing home sector, the home care sector, and housing for the vast majority of elders who live in the community. We shouldn't forget that. So that's some of the issues we're going to talk about tonight, problems and solutions, first wave, second wave, what have we learned? So we have a lot to do. Each of our speakers is going to address us briefly, 5 to 7 minutes, then I'll moderate a question period. I'll invite you to please put your questions in the chat box. I'll monitor it as we go along and try and integrate your questions into the conversation. So I want to start, I'll introduce the panelists very briefly. You see the names, you'll see their names on the side on a slide. And I, of course, won't do justice to their biographies, because if I did, we wouldn't have any time to talk. So very short Twitter-length bios for each of them. I'll start with Nathan Stahl, who's a staff geriatrician at Sinai Health System, very active in the media during this, this pandemic. Hi, Nathan, give us a wave. We have Carole Estabrooks, who's a nursing professor at the University of Alberta. She has great expertise in knowledge translation in long-term care, and a wealth of knowledge from years of running a research program called TREC, Translating Research in Elder Care. And she'll talk to us about the impact of COVID-19 and beyond. Say hi, Carole. Thirdly, we have Morgan Hofarth. She's the new RNAO president, and she's also in her day job, director of care at Mount Hope Center for Long-Term Care. And she's going to bring some real life frontline experience to the panel. And last but certainly not least is Wendy Francis of the Family Councils Collaborative Alliance, FCCA, who brings the all-important voice of families to the discussion. And in our last round, we didn't have a family member on the panel, and we were very unhappy about that we couldn't do that at the last minute. So really happy to have you here with us tonight. Wendy, say hi, and we'll get to look forward to your comments, that all-important family voice. And of course, we have Doris Grinspun, who doesn't need any more introduction, and she'll join in on the discussion a little later. So I thought we could start off with Nathan. Nathan, if you could start us off with a little bit of context, a little bit of data, set the stage for our conversation tonight, if you could.
Sure, thanks very much. So, you know, I continually build on this talk, and unfortunately, as André has highlighted up front, the numbers get worse and grim, and we sort of extend our figures to the right on the graphs. And my twin daughters are currently screaming, so apologies if you can hear that in the background. If we could just go to the next slide. I have no conflicts of interest to disclose. Next slide, please. So here's what I'll talk about. I'll talk about the epidemiology of COVID-19 in Ontario, but really in Canadian long-term care homes. As you'll see, this was mostly a phenomenon in Ontario and Quebec in the first wave, and that is simply not true in the second wave. We'll talk about some of the research that we've done in Ontario, looking at risk factors for spread and risk of COVID-19 outbreaks in long-term care home, and then a little bit about what the impact has been on long-term care home residents in general, not just those that have got COVID-19, but those who have been infected. Perfect. These are the curves actually just pulled from PHAC today. You'll see Canada on the top left. These are just all cases, the moving average of cases in the last 7 days. Our second wave has really taken off compared to the first wave comparatively. And you'll notice, look at the top right, Alberta, which is the sort of worst place in the country right now with the steep takeoff. Even Manitoba managed to have some control in the last, couple of weeks with more severe measures. Ontario, it continues on the up in what they call a precarious steady state, which is certainly precarious given the state of the acute care system and the long-term care system right now. Quebec, which you'll see has had some bumps with some intermittent or with some lockdowns, which they actually took earlier on. And then the envy of the rest of Canada, Newfoundland, Labrador, New Brunswick, and the next slide, please. Nova Scotia, Prince Edward Island, where they are the envy of the world, really. And the territories, these graphs aren't fair because the y-axis, there have been some devastating outbreaks, particularly in Nunavut, that we cannot capture without telling PHAC to change the y-axis. So they're not all standardized. Age distribution of cases. This has shifted dramatically. This is the majority of cases are actually in people under 50 years of age. You'll see that only about just over 20%, less than a quarter of all cases have occurred in people aged 60 to 69. If you look at the next slide, please. If you look by gender, the majority of cases across all age strata, with the exception of the 60 to 69-year-old age group, occur in women. That's primarily because of the bulge in the 20 to 59 range, probably because there are more healthcare workers who are women and more in other front-facing jobs. And then, of course, over 80, there are more women than men at that age group, with women outliving most men. Or not most, but tending to outlive men on average. The age by gender distribution of hospitalizations, interestingly, despite the cases, you'll see that actually men, and this has been shown over and over in the world, men have worse COVID-19 outcomes, with the except over 80, they do account for more hospitalizations, women, but that's simply just by numbers that there aren't as many men alive. So interestingly, men, despite having less cases, have been impacted more by this pandemic from a purely epidemiological perspective, not looking at the social perspective. And next slide, please. And then really what I think is of relevance to our population, this is age by gender distribution of ICU admissions. Even if you look at just the cases again by gender, women or men have had worse outcomes. But you'll see, despite the numbers that I showed you before, these are ICU admissions. If you could just go back one slide, sorry. If you look at hospitalizations, the actual, despite representing less than 25% of all cases, those 60 and above account for the majority of all hospitalizations in our country. So this is a disease that, despite the fact that it has been shown that cases have been more concentrated in younger age group during the second wave, older adults continue to account for the majority of hospitalizations, ICU stays, and then just please advance 2 slides. And deaths. So if you look at COVID-19 deaths, over 13,000 deaths as of December 13th, you'll see the figures are staggering in terms of the proportion of all deaths that have occurred among older adults. If you just look at those, and this has changed actually since the last time because there's been more deaths in the sort of middle age group, but the overwhelming majority, over a third, are over the age of 80. 1 in 5 deaths are those 70 to 79. So over 50% of deaths have occurred among people 70 and above. Next slide, please. What we know, and we've known this since Washington State happened, and since North Vancouver happened at the beginning, where the first 2 outbreaks in North America happened at the Kirkland, Washington, at the Lynn Valley Care Center, that long-term care residents are at high risk of contracting SARS-CoV-2, the causative infectious agent of COVID-19. They live in congregate settings, which are often crowded. There's exposure to staff, and the staff often live in some of the COVID hotspots. And there's challenges in this population with physical distancing and hand hygiene. 70% have dementia, 90% have cognitive impairment. And early on, this is from Washington State, there are shared healthcare workers between sites, something that continues to happen here in Ontario, even after orders being put in to restrict workers to one site. Next slide, please. And of course, they're at increased risk of morbidity and mortality. There's advanced age, multimorbidity. The case fatality rates, the number who die for those that are infected, have improved during the second wave. But there are difficulties in comparing the first wave to the second wave. We know now the case fatality rate is a proportion, it's a fraction, and we know that we are detecting more cases now, we're detecting cases earlier on. And the case fatality rates are still very, very high, somewhere between 1 in 3 to 1 in 5 long-term care residents who get infected go on to die from COVID-19. Next slide, please. So this is really, there's a stunning change in this. This is the National Institute on Aging Long-Term Care COVID-19 tracker. It tracks to long-term care homes and retirement homes, which are often forgotten in this conversation. If you looked at this chart in August, even beginning of September, you would see 2 provinces that really stood out, which still stand out, Ontario and Quebec. And Ontario and Quebec, Ontario's in terms of the total deaths, we're approaching 4,000 in our province. If you look at the resident deaths, we're at about 2,700. So it's about 63% of all deaths right now are in long-term care homes. And then you add the retirement homes and you get to about 70% of all deaths in our province of Ontario have occurred in congregate care settings that look after older adults. You look at Alberta now, though, of their homes, 205 out of 350 homes have been affected. There's now been 413 resident deaths. We see this in Manitoba now, 224 resident deaths. There have been catastrophic outbreaks in places like the Maples Care Home, where the Army has, or where the Red Cross has been called into some of these jurisdictions. And so this is not a phenomenon that's isolated to Ontario and Quebec. They still stand out for having thousands of deaths as compared to hundreds of deaths, but certainly the West has not been spared from the horrors that have happened in long-term care homes. Next slide, please. This is taken earlier in the pandemic. This is this figure that is often talked about in the first wave, where Canada, 80% of our country's long-term care home, or of our country's COVID-19 deaths occurred in long-term care homes. It's probably a little bit lower now in terms of intra-country comparisons, but at that time we had the highest proportion of all OECD countries for which we had data for, despite having a relatively lower number of deaths. One of the things that's often bandied around, and remarkably continues to be bandied around by the undercurrent of Twitter and other such places, even by elected officials, is that this is no worse than a flu season, or that the deaths we're seeing now are no worse than a flu season. So if you look at the yellow here, in Ontario, we actually had a remarkable period from mid-April to the end of June, where the coroner did an expedited death review on all deaths in the province of Ontario that occurred in long-term care homes. That's the 5-year average in the yellow. What is above that is referred to as excess mortality. So if you started 2020 and you said, what do we expect the deaths rate to be if the COVID-19 pandemic did not occur, you would sit somewhere in the yellow. But here we see there's been, just in that time period, there were 1,429 excess deaths from COVID-19. As we'll talk about, 160 excess non-COVID-19 deaths. So people died not from COVID-19, but from the conditions of the pandemic and the collapse of care around them. And so this is certainly, it pains me to address it, but this is way worse than a flu year. Even where we've had bad flu years in the last 5 years, the death rate during this time blows it out of proportion. Next slide, please. This I post every day, and what's really concerning to me, this is Ontario's data. So the orange line are resident active infections. The yellow line are staff active COVID-19 cases. The blue lines are active outbreaks. This is just from December 6th, and the cumulative deaths. So what you see here is a really strong intensification over the last month. So actually, over 50% of the long-term care COVID cases in the province of Ontario during the second wave, which is considered to have started on September 1st, have actually occurred since November 1st. And 80% of deaths have actually occurred since November 1st. So within that second wave, the majority of cases and the overwhelming majority of deaths have occurred since November 1st. And this is the intensification we're seeing where things are really getting worse in the sector. So today is a very hopeful day with the vaccine, but we cannot let vaccine euphoria get in the way of addressing the issues that still need to be addressed, particularly when we're experiencing maximal pandemic fatigue. So it's a dangerous combination, in my opinion, of maximal fatigue and vaccine euphoria. We need to celebrate science and we need to celebrate what happened today, but we cannot let that distract from the other work that still needs to be done. So briefly, just what are the factors we've identified in terms of risk and spread of COVID-19 outbreaks? The greatest risk factor for COVID-19 outbreaks, we've known this for months, is community incidence of COVID-19. This is data, we did an analysis with the Ministry of Health. What's really remarkable is the red lines are community cases and the bluish greenish lines are long-term care home cases. What do you know, except for the North region where the data doesn't really pan out because of the small number of outbreaks they had there from the first wave, these curves parallel each other with a lag of about 3 weeks. So when the community incidence starts to spike, you start to see cases within long-term care homes. The greatest risk factor for a long-term care home outbreak is community incidence. It's no surprise that we're seeing 1 in 5 long-term care homes in the province of Ontario currently having an outbreak because we're having surging community transmission. And it's anticipated by tomorrow, we're gonna surpass 2,000 active cases in our province. Next slide, please. This is work done earlier on. I know Doris has showed this multiple times. This is David Fissman's work, but just showing, this was early on in the pandemic that lagged staff infection was associated with death among long-term care home residents. And interestingly, well, not interestingly, unsurprisingly, your 13, if you just age matched individuals who lived in long-term care versus the community, and they are different individuals, and it's not, you are comparing apples to apples to some extent, but you're 13.1 times more likely to die in long-term care of COVID-19 than you are in the community, just looking across ages, without accounting for, we know, the higher prevalence of comorbidities that occur in the long-term care home populations. Next slide, please. This is work we did looking at for-profit status of the long-term care home in Ontario from the first wave. Again, for-profit status didn't impact the risk of an outbreak, but that was related to community incidents. But we saw that for-profit homes had outbreaks that involved twice as many number of residents being infected and had 78% more deaths. And this was largely explained in our analysis from the data that we had by the higher proportion of homes with older design standards and chain ownership in for-profit homes. Next slide. And finally, one of the things that's most concerning really across the country is the issue of crowding. We continue to have residents that occupy 3- and 4-person rooms in many homes. This leads to explosive long-term care outbreaks. We did a simple calculation where we looked at, let's look at the association between crowding, so the average number of residents per room and bathroom, and the incidence of infection and mortality. And the more crowding you have, the more infection you have and the more mortality you have. So we did some simulations that if you'd converted all 4-bedded rooms to 2-bedded rooms, we could have averted about 1/5 of all COVID-19 cases and 1/5 of all COVID-19 deaths in the province of Ontario. Next slide, please. In the last 2 minutes, and I may have extended my 7 minutes, so apologies, just the impact of the pandemic on long-term care home residents. I could say any number of things about this, and I know André has written about this because this article turned both of our heads in early May, where a bunch of long-term care physicians in France wrote about what they talked about the confinement disease being more deleterious than COVID-19 itself. The confinement disease or syndrome is actually terminology taken from prisoners who were put in solitary confinement, of which we know there have been several Supreme Court rulings that this is unlawful and is a human rights violation. And so if you go to the next slide, one of the things that came out of this is a new syndrome, the confinement syndrome, that I think many of us have experienced for those who work clinically or those who have loved ones in long-term care, is that we saw people who didn't die from COVID-19, but they died from the collateral damages of the pandemic, whether it was dehydration and malnutrition. I've had people who've gone from walking to wheelchair bound, from being able to recognize their loved ones to not being able to do so, have worsening of their responsive behaviors. And of course, there's also loneliness, social isolation, the psychological distress that residents and their families and their caregivers and the staff who work there have frankly all experienced during this terribly difficult time. If you go to the next slide, please, these are just some photos that have spoken to me from across the pandemic. This is an older couple in Winnipeg, just, you know, kissing through the window. That became sort of the iconic image of long-term care. The next slide, please. This one is quite remarkable. This is at Baycrest in Toronto. Someone hired a bucket crane because if you don't have a main floor window, of course, you can't do the window visits. And so they actually parked a window or a bucket crane outside the window of their loved one's room. The next slide. This was considered the sort of innovation of COVID, which is the hugging curtain. This is actually from Barcelona, an elderly couple embracing for the first time after months. And then the final one is a photo from Montreal over the summertime where an older adult is longingly looking out the window where the rest of society was opening up around them, and they were, you know, continued to be largely confined to their homes. So we tried to look at this in you know, a scientific way, and one of the things that we had heard over and over and over again was there's increased prescribing of psychotropics to long-term care residents, and so we looked at 4 drugs in Ontario over the first wave, and going back actually to March of 2019. We looked at antidepressants, trazodone, which is another sedative type medication, antipsychotics, and benzodiazepines. You see the blue line is actually the secular trend that preceded all this for a year and a half. And you see it generally follows that. I'll draw your attention to the y-axis. These are not huge changes. These are the absolute numbers, but we have over 70,000 long-term care residents in the province. So you see a sharp takeoff of things like antidepressants, trazodone, with that line being March 2020, antipsychotics. So, you know, these are 2% to 3% changes, but when you're talking about 70,000 people, you're talking 1,000 to 2,000 new residents that were put on these medications in a short period of time. And then we looked at other medications we didn't expect to change. Metformin, which is used for diabetes, and statins for high cholesterol. Those medications actually went down, either meaning that the people who were receiving those were more likely to die because we know diabetes and high cholesterol are risk factors, or those medications weren't refilled with the same concentration as the psychotropic medications were that were being used for a number of reasons to, you know, treat distress that people were experiencing, to treat responsive behaviors that were occurring in people living with dementia because they weren't having access to their caregivers. There was a collapse of care system around them, so non-pharmacological approaches couldn't be pursued. So this was just we tried to get some of the objective sort of evidence to show that there was harm to residents, which is obvious from the stories, but data is sometimes powerful in a different way. And so with that, apologies for exceeding my allotted time. I will hand it over to the next panelist, and thanks very much for listening.
Great, thank you very much, Nathan. Very thorough, and we'll forgive you the going over time because there's a lot of data there and it's generated lots of good questions, which we'll get back to. So I want to turn over the virtual floor to Carole Estabrooks. Carole?
Great, thanks, André. Next slide. So I'm going to talk a little bit about, back one, about potential solutions. But before I do, I'll just say what the blindingly obvious is that's been in front of us for some months is that the COVID-19 virus didn't break the long-term care system. The long-term care system has been broken for decades as a result of years of neglect. We can blame the federal government, and they share some of it, and we can blame the premiers and the provincial governments, and they certainly stood watch over the catastrophe. But to really get at what we need to do, we've got to look in the mirror, which is something that's really difficult to do. We have to talk about getting old in this country, and we have to talk about getting dementia in this country, and we have to talk about death, because much as we try to avoid it, it's an inevitable outcome. The questions become, how is it that we can expect to age in Canada? And how is it that we can expect to age if we have dementia? And how is it that we can expect to live our last days? And what kind of a death can we expect? So those are tough questions, but that's what we have to do. I chaired the Royal Society report, and by the time we'd skimmed through 50 years of reports and media, it was beyond heartbreaking, and there was more than one set of tears shed. The same reports have been written for 50 years. They've said the same things. They're produced, and when the media attention passes, the reports are put on a shelf, and maybe if we're lucky, one or two things are done. So we argue that the last thing we need now is yet another commission or inquiry, a panel, or report. They of course have sprung up. but rather what we need is some kind of an action force so that we can get past federal, provincial, jurisdictional squabbling and our inertia that's developed in the system and really move. So the next slide. So I want to talk a little bit, I'm not going to talk much about dementia, except to say you can't talk about long-term care and ignore dementia. It's the leading cause of death in the United States, and it's the leading cause of admission to long-term care. Not everybody who ages by any stretch of anybody's imagination needs a nursing home, but for those who do, whose needs have overwhelmed the family and the community and the people who care for them, it can be the right place to be if it's done well. And I think what COVID has pointed out is just how not well it's being done in this country. Next slide. This was a slide that really, I don't know why some slides, some reports take you back more than others. This looked at excess deaths due to dementia and Alzheimer's since March in the United States in the community. So these are people who died not from the bug. The bug is bad enough, but Nathan has talked about confinement syndrome, but people who died from the conditions created by the virus. And that has been in no small part one of the major tragedies of COVID-19 as it's been experienced in long-term care. It's the conditions that this accursed bug has created in a system that was already creaking under the strain of years of neglect. Next slide. So we did a study in the West, and we're updating it now. We just haven't got it updated, but what we were interested in is what has happened to length of stay in nursing homes. And what's happened, at least in Alberta and with the Winnipeg region, which is the only Manitoba region for which we have resident data, is that it hasn't changed much in Winnipeg. In fact, it's gone up. That's a reflection of the Winnipeg region having people in nursing homes who don't need to be there. They could probably be better cared for in retirement homes or assisted and supportive living. In Alberta, there was a deliberate strategy in around 2006-07 to age in the community and age in place, and very assertive policies and practices put in place to delay nursing home admission and drive the length of stay down. And that's a good thing. They were successful at doing that. But what this slide hides beneath this nice success story is that when you do that, your people who come to a nursing home, your old adults, they come later in the trajectory or course of their illness or their dementia with much higher social and healthcare needs. So they have much more complex needs than they had 15 or 20 or even 6 or 8 years ago. So that's first part. Next slide. I just picked this one out to illustrate that this is a workforce, a set of workforces under enormous strain. So I'll just break that out for you. There's 3 parts to the burnout scale. The top 2 are bad and the bottom one's good. And then it just goes PSWs, RNs, LPNs, and your allied professionals. I'm just going to focus on the care aide or PSW, which is the top bar in each of the 3 pictures. That red area is the proportion of care aides or PSWs who are at high risk for burnout, whether it's through mechanisms of emotional exhaustion or cynicism. So in the middle picture, 50% of the workforce is under high risk for developing symptoms of burnout. And we know that burnout has adverse consequences on both the person having it, quite severe in fact, but also on the care they're able to deliver and ultimately on care outcomes. That's the bad news, and this was pre-COVID. So I anticipate when we go in next year, we'll find significant changes here. The bottom picture is a good news story. It does tell us that all of the workforces in long-term care, in particular the PSWs and care aides, also report and express these really high levels of what the researchers call efficacy, but it's the sense that one's work has meaning and purpose. And that's a really good sign. You don't see those high levels in other settings. That probably helps buffer against the negative outcomes of burnout. And it may signal some capacity in the system that we may not realize that we have. However, I would predict that we might see more negative areas in these graphs in the top 2 negative scales and maybe a little bit less positiveness in the bottom one, but we'll have data to demonstrate that. That's intended as a way to show you one way that this workforce is under duress pre-pandemic and has been for years. Next slide. So we walked into the pandemic with a perfect storm already brewing, and then COVID happened. And why we would think, what on earth would make us think that we wouldn't have a catastrophe is incomprehensible. So of course we did, not just in the excess mortality. Death is not always a bad thing, but in the way people died and the suffering that took place among residents, among families, and among staff. And staff, frontline staff, yes, but all the way up the chain. No respectable owner that I know felt anything but just anguish during this period. So the question is, how do we address this? How do we dig ourselves out of this? The other thing that's happening in this area, or in both the residents and the workforce, is they're both highly vulnerable. So I won't go over this in detail, but what it's meant to illustrate is that the older adults in these nursing homes, they're vulnerable because they're old. They're vulnerable because they have dementia. If they're poor, they're more vulnerable. If they have a history of traumatic stress, that increases their vulnerability. If they have a history of mental health and addiction issues or homelessness, et cetera, et cetera. So there's a large proportion of people in nursing homes, residents, older adults, who have multiple compounding vulnerabilities, and it makes them so frail and so much in need of our very best care, the best care that we could offer in the system, which is far from what we've been able to offer, or chosen to offer, I should say. Next slide. The frontline workforce, in particular, the PSWs, are largely women, older, predominant, over half in urban centers are immigrants and speak English as a second language, so it's a racialized workforce. Over 20%, in fact, if we look across the entire West, it was closer to a third of carriers were working in more than one home pre-pandemic, and they come with their own histories. So the hypothetical older worker has her own set of compounding vulnerabilities. If we don't think that COVID-19 and what's going on pre-pandemic and during the pandemic, and maybe, well, hopefully not post, but it probably will be, in long-term care isn't an issue of all these vulnerabilities plus hardcore ageism, hardcore sexism, and hardcore, I don't think it's a word, but dementiaism, we'd be mistaken. So why would I say sexism is such a deal? Well, we've taken advantage, I would submit, of a vulnerable frontline workforce who are predominantly women. We don't value the work of caregiving, so we don't remunerate it. Many aides in many jurisdictions weren't making enough money, weren't making a living wage. So that was one of the main reasons they were working multiple jobs. So because we don't value caregiving, which is predominantly women's work, and because, well, anybody can take care of a complex older adult with dementia, right? I mean, just get some poor, racialized, poorly educated women and don't pay them as much as you really should. And I mean, so it's those isms that have led to the conditions we've got, and they're hard to face, and they're not even nice to say, but we're going to have to talk about our attitudes toward older adults and towards the value of caregiving, and stop thinking about kind of broadly writ large nursing care as domestic labor, and start thinking of, not that domestic labor doesn't have value, don't get me wrong, but start thinking about what is it that these older adults require and who can best offer it, and how do we properly remunerate them. Next slide. Next slide. I'm going to talk for just a minute about the work environment. So we've been doing a lot of work for the last 15 years about the work environment. We call it the work context. And so what we can now demonstrate is that if you've got a better work environment, you will have better staff outcomes and better resident outcomes. So this shows just one thing that we looked at, a care process. We asked care aides, and probably we would do 5,000 or 6,000 in every wave we do. On the last shift that you work, how many things in the list did you leave undone because you didn't have enough time? And the results are actually quite shocking. Walking and talking, which are two critical dimensions of quality of life, but other even more fundamental things. But if you're in a green home or a home where there's a better work environment, you leave less things undone. So why is that important? Just by changing the environment, working on the pieces that make up environment, leadership and culture and teamwork and communication and resources, in combination, you can reduce unwanted outcomes and improve wanted ones. Next slide. And the same goes for resident. No, back one, please. Oh, I've left one out. I seem to be missing a slide. What I should have in here, but I don't, is a slide that also shows that if we look at symptom burden in the last 12 months of life, for example, shortness of breath, pain are two that we've looked at, distressing symptoms that are really unpleasant and difficult and not entirely, but largely modifiable, they go up as you approach death. And they shouldn't. We need to bend that down and lower it overall. But in homes that have a better work environment, they have lower rates of pain, lower rates of shortness of breath, lower rates of pressure ulcers, lower rates of delirium. So just by changing the work environment, we can improve the outcomes for both the staff and the residents. So that's hopeful. That's good news. These are fixable things. We know what to do to address these issues. So the point being, I suppose, that this can get really despairing, but we have a lot of things that we can do that will improve the critical workforce issues that we're facing, which are probably a significant piece of why Canada's performed so badly in long-term care. We have much thinner ratios of professional staff in long-term care than many other countries in Europe, for example. So this slide is what we've come to normalize, back one, please. Not in every nursing home in Canada, but in many nursing homes. Still back, I would like to stay on the blue slide for a minute. I mean, they might be trying to hustle me along so that I stop talking, but I'm going to stay here for just a second.
Are you on the right slide now, Carole?
Yeah, this is good. Yeah. So 70% of people in long-term care in Canada are in wheelchairs, and we've normalized this as if it has to be this way. And this is just absolutely fallacious. We can have environments where 70% of our people aren't in their wheelchairs. They aren't bored. They don't wake up in the morning. We can have an environment where they do wake up in the morning with some sense that there might be a moment or two of pleasure in the day, that there might be something to look forward to, that they might be able to taste their food, that there might be intergenerational experiences, that there might be animals, that there might be sunshine on their faces, little things that make up a good end of life and a purposeful, meaningful last stage of life. This is possible, but when we get ourselves in this mindset of institutionalization and medicalization and task orientation and risk aversion, we lose sight of what we should be doing. And these are homes. These are not chronic hospitals. These are homes. So they're not just health care and quality of care. They're social care and quality of life. And quality of life, as everybody in the industry knows, that's the holy grail. Quality of care is in the service of life quality. Now we'll go to the next slide. There are lots of models we can think about and talk about. But I'm just going to use green farms because they're my current favorite as an example. This is a model that's quite popular in parts of Europe. There isn't a ton of evaluation, but there's more evaluation on this than many of them. So in these places, people have to help prepare the meals. They have to be mobile because they work in the garden a little bit. They gather the eggs, they tend the animals, they do the things that were part of their normal lives. And yes, they're monitored and there's staff there. They're allowed to use knives to chop vegetables, heaven help us, so they're not as risk averse. They structure it so that you have to walk to the dining room. They get sunshine and snow and rain on their faces. They can smell flowers. They can touch things that have different tactile experiences, and they feel like they're making a contribution, and they are in their way making a contribution to a community and to a limited degree to their own sustenance. And I suppose one could scale these to provide sustenance elsewhere. One of the most startling things, at least in my understanding of what I've learned about them, I had a student last summer there, and I said, find out what happens when they aren't able to stay anymore because their dementia advances and they have to go to another facility. So she came back and I said, well, what happens? She said, well, it's really strange, Carole. She said, they go along and they go along and they go along, and maybe they slow down a bit, and then all of a sudden they go to bed and they die 2 or 3 weeks later. And I thought, well, isn't that just the way most of us would like to go? So they're keeping their population mobile longer, and there's a steeper, quicker decline, no less of a length of lifespan, but a very different end of death. And I think that we need to think about ways that people, I think a Canadian gets to have this kind of an end of life, even with their frailty and their infirmity and their dementia. But if we want to create this, whether it's a green farm or an equine farm or a dementia village, or there's dozens of models out there, we have to choose to do it. And then we have to figure out how to resource it and how to make a commitment and stay with it. So there's hope here. We just have to make the choice as Canadians and as governments and as healthcare professionals to do this. Thank you very much. I appreciate your attention.
Great, thanks, Carole. Lots of rich content there. Again, generated a lot of questions, which we'll get to. I really retained a couple of really important things, I think, from what you said, that this is really a gendered, ageist, racialized pandemic, and we can't forget that, can't lose sight of that impact on minorities like that. And also that good care requires a healthy workforce, and we forget that one too. We kind of neglect our nurses and PSWs and physicians. Now, next, I want to turn over the virtual floor to Morgan. If you could talk to us a bit about life on the front lines.
Thanks, André, and thanks everybody for attending. I'm Morgan Hofarth, and I have the privilege to support the care of 394 residents that call Mount Hope Centre for Long-Term Care home. I came to long-term care during the pandemic, so I have worked for St. Joseph's Healthcare London for the past 9 years in a variety of different roles, and during the pandemic was working in the complex care program and was redeployed to open what was intended to be a COVID treatment unit for up to 40 individuals who had COVID, which very quickly turned into not a COVID treatment unit, because what the need in our city was to decant some of the patients from our acute care hospital who were waiting for long-term care. So our 40-bed COVID treatment unit very quickly became a 40-bed subacute medicine unit, where all of our, at that point, patients became residents who were waiting for long-term care. So I worked on that unit, opened it, and worked with that patient population early in the pandemic from March to June. And that really kind of reignited for me my love of the care of the elderly. So I worked as a healthcare aide when I was doing my undergraduate in nursing, loved that role, loved working with that resident population and being able to kind of provide those quality of life interventions for residents. And because of my work being redeployed during the pandemic, decided that I would apply to the director of care position at Mount Hope Centre for Long-Term Care. And I'm very fortunate to be able to work with an excellent group of staff members who really care about the residents that we provide care for and who call Mount Hope home. We are located in London, Ontario. So early in the pandemic, did pretty well. More recently, have become a red region as of today. But we've been very fortunate at Mount Hope to not have any, if very little, COVID in our home. So we have had a couple of residents who have tested positive. We've been very fortunate not to have any resident-to-resident transmission. And we've also been very fortunate with the few staff cases that we've had not to have any staff-to-staff transmission. Because I think, as a lot of both Nathan and Carole have alluded to, once COVID gets into a long-term care home, it can be really devastating and very deadly for the residents. It is very difficult to tell people in their home that they can't go close to other people. It's very difficult in the resident population that we serve to always keep them 6 feet apart without socially isolating them so much that they really kind of sink into deep depression or suffer the other unintended consequences of the pandemic. So today I am going to talk a little bit about what some of the challenges are, but also what I would identify as some of the opportunities from my short time in long-term care, but also in connecting with the staff members who have spent their career in long-term care at Mount Hope. So definitely some of the challenges that long-term care faces is staffing levels and funding. It is an area where it's very difficult to recruit and retain staff. It's difficult to attract staff to long-term care. And I'd say there's a lot of different reasons for that. So when you look at nursing, for example, it's not really for a lot of people and for a long time has not been identified as one of the like sexy areas to work. It's not somewhere that really, there's not a lot of clinical placements in long-term care for RN students working with the RN in long-term care. And it is an area that has had pretty bad media coverage where people have not really, a lot of people would not be drawn to work in long-term care. I really think we have an opportunity to change that. I think the COVID pandemic has really shone a light on long-term care and the work that people do in long-term care as really being meaningful and important. And I think that we need to continue that messaging and continue to explain the work that we do to people who've never worked in long-term care, maybe never spent a lot of time in a long-term care home, to understand that this is really important and meaningful work. It is challenging and complex. And what we're asking nurses and PSWs and all of those who work in long-term care to do is difficult work. And you need specialized knowledge to be able to do this work. So I think the more we can continue to really shine the light on the importance of elder care and the importance of the specialty of elder care will make a big difference in helping to attract staff members to want to work in this area. One of the difficulties is the increasing complexity without increasing funding. So looking at, as we've seen earlier in the presentation, people coming into long-term care later in life. I heard a stat recently about kind of the typical length of stay in long-term care is about 18 months. So residents aren't coming to live for years and years for the most part in long-term care anymore, which means they are more complex when they come. And it is really difficult to provide the care that they need without increasing the funding. But with the funding model and the case mixing that's kind of lagging behind the residents coming, it doesn't really match up with the residents that you have in your care at that time. So we definitely have seen an increase in complexity. I can tell you from working in long-term care 10 years ago to working in long-term care now, there is a huge difference in the complexity of the residents, in their mobility, in their cognitive functioning, in their ability to perform any of their ADLs on their own, as well as the medical complexity that we're seeing in long-term care. One of the other challenges is pay equity. So I'm very fortunate to work in a long-term care home that pays on par with our acute care hospital. So we don't have that challenge in the long-term care home that I work in because the pay for our staff members is the same as if they were working in the hospital. But I know that that is a significant challenge in other long-term care homes. Because they can't pay on par with other sectors. And a lot of people would leave long-term care for a better paying job. I would say there is also a significant workload for leadership within long-term care. So I have been there for 6 weeks, and it is definitely an increased workload from my previous leadership position. And leadership turnover in long-term care, at least in Ontario or in the region that I live in, has been really significant. So most directors of care or associate directors of care are typically in their role for about a year, which makes it really difficult to move projects and to move quality forward. Lots of reasons for that. So it could be the workload, could be some of the other things we talked about, like the bad media coverage, the kind of constant scrutiny that you're under in long-term care that you don't maybe experience in other healthcare sectors. But I'd say there's definitely a lot of reward. So I was talking to one of the staff members today and said, what would you see as the biggest opportunity in long-term care? And this is someone who's worked in long-term care for a very long time. And they said, you know what really would make a big difference? If we could give back more memorable moments. And they were talking about how 10 or 15 years ago, staffing ratios were better, and you really had that time to be able to sit and talk with a resident or to do something meaningful for them that really made a difference, and how that really was provided them a lot more reward in their career. They felt a lot better about the care that they were able to provide when they had a bit more time. So if we talk about improving staffing in long-term care, I would be remiss if I didn't mention the nursing home basic care guarantee, which RNAO published recently, looking at the 4 hours of care for all residents in long-term care homes and specific staffing ratios for PSWs, RPNs, and RNs. I think that would make a huge difference in the quality of care that we're able to provide to the residents in long-term care, but also would help improve the quality of life. When you have more time to spend with your resident, when you're not rushing them in the morning or in the evening because you have a lot of people that you have to get dressed, that you want to do your best job but don't have the time to, it would make a huge difference in the lives of the residents that we take care of. So I would say that's what I would identify as the biggest challenges, but also opportunities from my limited time in long-term care.
Great, thank you. Thanks for giving us a good portrait of what's going on and some of the challenges. I want to turn now to Wendy Francis. Wendy, can you talk a bit to us from the family perspective? This has been, this pandemic has been really, really hard, not only on residents, but on their loved ones as well.
Thank you so much, André. I really appreciate it. And thank you so much, Doris, for inviting us. Basically, the Family Councils Collaborative Alliance here on this first page, we basically just organized this year, and of course then launched our podcast in terms of the Long-Term Care Chronicles to be able to just provide educationals to individuals to let them know as to what the issues are that have been happening prior to the COVID-19 as well as during the pandemic, as to how that impact has impacted a lot of families. Can we go to the next page? And then we'll just go through the agenda here, which is what, so thank you. And then that's fine, just go back to the introduction. The next page. Perfect. So basically, we're just a newly formed group. I'll just start, and then started in January of different family councils. And basically, we just came together to share our experiences, our knowledge to family councils and their members. And in order to get our message out, we created the Long-Term Care Chronicles podcast as a meeting to discuss the issues that were impacting family members and their loved ones in long-term care. Next page, please. And family councils are usually made up of spouses, sons and daughters, grandchildren, brothers and sisters, nieces and nephews, friends, and persons of importance. Next page, please. And then we'll just talk a little bit here about the anticipated lockout. Next page. And basically, overall, the communication was unclear and, and the provincial government and the long-term care facilities. Families were subject to all unknowns on what would happen to their loved ones without their personal care during the lockout of COVID-19. And of course, access was denied. Next page. And so during COVID-19, next page. So we have a timeline here in Ontario, where on March 13th, there was the guidance provided in terms of having the lockout came into effect. It wasn't until June 11th, then the outdoor visits were then provided. And on July the 22nd, then indoor visits were provided to family members. And then on September 9th, the directive was updated to allow for recognizing family members as essential caregivers or essential care partners. And then on November the 23rd, again, the directive number 3 was updated and allowing family members to go allowed into long-term care. Can we go to the next page, please? Now, there's 3 examples where we've had all of these facilities all experienced the outbreak in their homes. However, there was 3 different situations that came about that. So from this first experience, basically this particular family, after more than 2 months of being locked out as an essential caregiver, have just been allowed back into the home as of December 9th. The facility received a non-compliance published online on December the 4th for violating the residents' rights to have visitors. At the home, the essential caregiver must have rapid tests every 3 days administered by the facility. Only 2 essential caregivers are allowed in each week, so it may be impossible to go in by the caregiver every day. We are unclear with this communication because all this started on December 9th, so very recently. And basically the lack of information and contact from staff about residents We are getting only one 50-minute call a month to get information about our loved ones and to ask questions. Next page. So this is another family member, their experience. Again, their home was in outbreak as well. And the Ministry of Long-Term Care recognizes the staff, that staff testing may not always be exact 7 days apart for practical reasons, but the wording is far more ambiguous for designated caregivers. Some of our members are looking forward to the convenience of rapid testing on site, but in at least one long-term care pilot, the caregivers are being subject to weekly lab testing plus 2 rapid tests per week while they linger in the lobby for 15 to 20 minutes awaiting results. Again, the unclear message from the Ministry of Long-Term Care, the directive, management, facility confusion over the specifics of weekly testing and designated caregivers. We finally received definitive clarification from our Homes Administration last Friday evening, December the 3rd at 8 p.m. And our last example here, where this particular facility recognized immediately the family caregiver as the essential caregiver. And here, I'll just go ahead and explain in terms of that particular process here. So it was all initially communicated by family members, was done one-to-one, then eventually a bi-weekly communique would be issued to inform all families at once. After the lockdown, administration quickly acted by purchasing new infrastructure to help and assist in the reunification of residents with their family members virtually and with weekly calls. The long-term care home decided to follow all of the Ministry of Long-Term Care directives, including recognizing essential caregiver, essential care partner, allowing two caregiver visitors per resident daily as deemed required by the essential caregiver partner, even if there is an outbreak moving forward. Next slide, please. And during COVID-19, we can see that there was 80% of deaths due to COVID-19 that occurred were in long-term care home. Next slide, please. So post-COVID-19, the future of long-term care. So we have here the family members are asking all tiers of government, municipal, provincial, federal, to create a national standards. Families are requesting to take profit out of long-term care. Family members are asking to be recognized here in the province of Ontario, Bill 203, as the essential care partner, and that they be a stakeholder at the table. And family members are asking for the re-imaging of long-term care and to make home care a priority and to look at other models of care to age well at home. Next slide, please. And in closing, next slide, please. We'll just take a quote here. We need to work together to fight COVID-19 and to keep people healthy, safe, and supported. Working with the provinces and territories, the government of Canada will do whatever it takes to support Canadians through this crisis and build back better once the virus has been beaten. Right, this quote has been given by the Right Honourable Justin Trudeau, the Prime Minister of Canada. Next slide, please. And in closing, families should never be locked out again as the lives are at risk. People are being diagnosed earlier in life with dementia and younger people are becoming more caregivers. How will we adapt to this change? There needs to be a re-imaging on care for aging in this country. Next slide, please. And again, thank you so much for inviting me. And this is our contact information for the Family Council's Collaborative License. Thank you.
Thanks a lot, Wendy, for joining us and for that presentation. We'll have some questions for you in a minute. I'll just remind the participants, please make sure your mics are muted. We had a little bit of background noise there. I was enjoying someone's TV show at the same time, but I'd like to do that after the panel. So thanks. Just make sure your mics are muted. Doris, do you want to say a few words before we go? We have a lot of questions waiting, but say a few words and then we'll go to the questions.
Very good. So just to remind everybody a bit of where Areneo stands with all of this, we agree, obviously, otherwise wouldn't be doing this, with all the comments made by our colleagues about the many issues. We are concerned that if we don't focus as an association on something specific, because next week is supposed to be an announcement, we are once again going to get nothing. Nothing, because governments are more focused on who to defer to versus actually to invest in this sector. So the basic care guarantee we spoke before, you know it. Next one, please. The recommendations that we issued last week about IPAC, André, I don't know if you know, but only 15% of the homes have a person dedicated to IPAC, 15%. The other 85%, it falls on the director of nursing, persons like Morgan, associate directors of nursing, even though it is in the Nursing Home Act. That tells you how little really we are willing to put anything on the sector, even on the midst of the pandemic. Next one, please. National standards, you all heard last Thursday yet again, the Prime Minister saying we want to focus on national standards, and the jurisdictions, our premiers and leaders saying, yes, give us the money for transfers payment, don't tell us what to do. Next one, please. Next one, please. And so hence why we're putting ongoing pressure on the federal and provincial, more the provincial in this case, government to actually next week announce concrete issues, especially mandating the 4 hours for senior in legislation. And we are doing it now with seniors. So we are in a campaign, and any of you online that are family members, please tweet, send us pictures with your loved ones, with your seniors, with their realities, their stories, so we continue to put the pressure in government to deliver on their promise, but yet to be seen Christmas present of the 4 hours of care. Thank you, André.
Great, thank you, Doris, for that. So let me just jump right into the questions. I'll start with a couple for you, Nathan, that came in. The question about, you mentioned this problem of confinement disease, the collateral damage of people who died of not of COVID. And people are wondering, do we have a sense of that number? Is it actually worse than COVID? Do we have any Canadian type data on that?
We don't have a lot of the quantitative data. What we do know happened during that time for people who work in the homes, like Morgan can attest to, is one of the big measures that we often rely on is the RAI indicators, or the resident assessment indices. And there was difficulties with getting this comprehensive assessment done, and done in a timely manner. So there was some lack of completion and lack of timely completion of this. We are starting to get some of this data from the first wave, which will help get at some of these sort of harms that people like, or that, that testimony, important stories like Wendy and others, like the for those of you who have read the commission, the Long-Term Care Commission testimony by the Ontario Resident, or the Ontario Association of Resident Councils have given. These are really important stories. We're hoping to be able to study that data as well. It's going to be hard. I think the excess mortality will be the sort of, as Carole has shown and as I showed, that's the true measure of the pandemic. The problem is, in terms of what was worse and what caused more deaths, there was such limited access to swabbing early on that I'm certain we missed people who had COVID-19 who died of COVID-19. And so even in the US, where their deaths as a proportion of the national population are lower than us, there's certainly a large number of nursing home residents who died of COVID-19 that were never captured as COVID-19 deaths. At the end of the day, I don't really think it matters. I think, we failed to protect them from COVID-19, and we failed to, provide in many places conditions that preserve the health and well-being of older adults during this pandemic. And, what was worse, who knows, right? And we may never have that data. And as I say, some of the data may never come in because of the redeployment of people who were doing the resident assessment indices. But we hope to provide or shine a little more light on that topic.
But you mentioned, I hear people every day say, well, it was just, they're old people, they were going to die anyhow. This is the point you're reiterating, is these are excess deaths. These are people who weren't going to die in the short term.
Yes, absolutely. And, the slide I showed of someone dying of malnutrition is almost unheard of, right? From a coroner's report, unless, of course, there's a decision made to pursue comfort care, and this was not the case. So things happened. I see some feet in Morgan's background. Sorry, I got distracted. These were things that happened that, that were never seen before, right? That, like, conditions that happen. So, you know, that Carole has talked about the ageism, the sexism. I call it dementia-related discrimination, the racism within the workforce. I mean, as we've talked about on previous webinars here, there are intersecting forms of discrimination that explain inaction and continued inaction on the sector. And yes, the sort of ways that these lives are cast away as, you know, they were old and they were going to die anyways, that's unfortunately continues to be a prevalent sentiment when many people continue to view the statistics as, you know, expected or unavoidable deaths, and that's tragic and should disturb us all.
Okay. Wendy, I want to turn to you. People are wondering, you know, on a more personal side, how do you cope with this being locked out? It must just drive you completely crazy.
Thank you, André. No, it's been very heartbreaking and very hard and stressful on a lot of the family members. The only thing that is coming together to be able to talk about their frustrations, to say what, you know, your facility is doing from another facility, but it actually has been very heartbreaking to see and to know. And I think that's why so many people have just become immobilized to kind of talk and to still continue to champion for some sort of change to be able to happen.
But it's got to be hard to just not, you know, want to hug your loved one and not be able to do it for months and months.
It is extremely hard because everybody wants to find a way to be able to connect with their loved one and not just be able to be through a barrier for the connection to happen. And that part is just not making it very easy at all. And there doesn't seem to be, for some facilities, an easier way to make that happen. That's the harder part.
And I'm also going to refer you to one of the questions in the chat. If maybe you could send a message, someone's wondering how can they join a family council? How can they get involved? So maybe you can answer that one in writing, and I want to jump over to Morgan. I have a couple of questions about, you know, the pay equity issue. People they're kind of shocked that you kind of alluded to the fact that you don't necessarily get paid the same in a home as in home care, as in a hospital. Why can't we fix that quickly?
That's a great question. So there's lots of places across the healthcare sector where pay is not equitable for people who are doing the same kind of work. So, for example, home care is typically an area that's underpaid. If we look at primary care, family health teams, oftentimes long-term care homes, nurses, PSWs, other healthcare workers aren't paid equitably across the entire sector. It used to be a significant issue for nurse practitioners as well. There has been some ground made on that. We're not at complete equity yet. How we get there, I think, is a collaborative advocacy effort to make sure that we are sharing with government that there is a discrepancy that exists, and to highlight the challenges that exist in those sectors because of that discrepancy. So like I said, I'm very fortunate to work in an organization that pays on par with, so we pay on par with hospital or with acute care. But there are lots of long-term care homes that don't, and it can be a significant barrier to get people to work there. RNAO has been doing ongoing advocacy for this, specifically around RN wages for as long as I have been an RNAO member, and will continue to advocate for pay equity across all of the sectors.
André, if I can add, it links directly to the comment that Morgan made before about what counts as knowledge, and that also Carole spoke before. The fact that it's more sexy an ICU versus long-term care. The fact that a hospital that is a hospital for children send people to long-term care homes as is everybody can take care, is taken as women's work. Again, the issue of gender is there, whether it's PSW or RN or RPN or NP or a physician for that matter, is talked as women's work is free work. That's critical. What is most concerning in Ontario specifically is that we are centralizing the new reforms completely around hospitals. You see that hospitals are now given to manage nursing homes. You see that hospitals are building new nursing homes. You see that now Hospitals, basically we now assign 850 ALC beds for hospitals that are in hotspots. Hospitals now will have the right to do home care. So you can only picture, unless we will unionize everybody, that it will only get worse, André. The differences will only get worse because we are preferencing hospital care and hospital resources above any other resources. And that's a new phenomena. It's a COVID-sized phenomena that will get us into more trouble vis-a-vis the type of models that we spoke in ECHO of community care, of thinking of nursing homes as the home of people, the models that Carole spoke, or Nathan or others, Samir have spoken, and many others that, including Carineo, that we say, how about, you heard Shirley last time, how about home care in the home of people, even trying? Or in ECHO, we said, how about building smaller homes where people can be more engaged in life skills, not only illness or perceiving everything as a deficit. What's going on in Ontario is very concerning now.
And Carole, maybe you could wonder if you could speak to that a bit about this medicalization. You talked about the need to emphasize quality of life rather than medical care. We don't always think in those terms.
Yeah, thanks, André. If you think about what a nursing home is like, before COVID ever hit us, it's an extraordinarily constrained environment where we violate, I would submit, civil liberties on a daily basis. We take away the right to mobility, we take away the right to choice, we take away the right to risk, we take away, so it's an extremely risk-averse environment. And if you medicalize the system and start counting your tasks, that's what you get. And it's not even that complicated. If you think about how you want to live, if you're old and infirm, that can translate into a nursing home setting. You don't want if you go into a nursing home, how many old people do you know who will look around and say, God, everybody here is so old? And we sort of chuckle. Well, maybe the reason they're saying that is because it's not normal in the world to only see people who are 82 everywhere you look. So we take away the things that make our lives full and rich. And when you let the medicalized health professionals at it, we turn it into an environment where we obsess about, don't get me wrong, there are a lot of quality care challenges in the country, but where we obsess and privilege quality of care over quality of life. You can't do that. They go hand in hand, and there is risk in life. I've never talked to an older adult who could have a conversation with me who thought they weren't going out of the facility feet first. They know they're going there and it's the last stay, and they want it to be a good stay, not a place that's fraught. And we have to keep talking about dementia. Like, if you can imagine, if I think about Nathan's confinement syndrome, I can't remember the word he used exactly. So you're old and you've got dementia and you haven't got really good hearing and you haven't got really good sight and you're not processing right. And now everybody's coming in a mask and a hazmat suit and their voices are muffled and you can't see their faces and you don't know them anyway. If you think about the kind of fear that must be present and the kind of suffering as that person dies, that's the antithesis of what we want to do in a care setting. And it's a perversion even of good medical or health care. So it's about choices and stopping medicalizing it and treating it like either a chronic hospital or an Elizabethan poorhouse, which is, sometimes what we do in this country.
Right. Now, Morgan, I want to come back to you because you mentioned during your short talk, you talked about my love of care for the elderly was reignited. And I was struck by that because I don't hear that very often. I hear a lot of stereotypes about, oh, I don't really want to work there, it's awful. How can we make that visible that this is a great place to care?
I think by people talking more about their experience in long-term care. So hearing more from people who work in long-term care. Before COVID, like when was the last time that you heard a nurse who worked in long-term care being featured in the media, being featured in a panel presentation, talking to nursing students about their career and why working in long-term care is a great choice? Like it wasn't something that people really talked about wanting to do. Definitely, there are nurses who have worked in long-term care for their careers who would tell you it is the best place to work. It is the work that they love, and that they really feel like they make a significant difference in that area. But it hasn't really been a popular place to work. But I think talking about the unique work and the unique perspective that people who work in long-term care have, and that really unique ability to make a difference in, this is the people in long-term care, like this is their last stop. This is the last place that they are going to live, and to be able to provide dignity to them at end of life and to be able to make their lives better just by being there and providing them with the quality of life that they deserve to have, I think is really something that is important.
You try and make it a home where you would want to be when you're older, it sounds like. Okay. And I want to say, I want to add.
Yes, sorry, the fireplace is going a bit crazy. So yes, making it a place that you would want to live and care that you would want to have if you had to receive care from somebody, making it the kind of care that you would want to receive, and thinking about like each individual as a person, and thinking about, like, I love hearing the stories of the residents and talking to them about their lives and what they did, and hearing about you know, their history and what they contributed to society during their life, about their families, about what's important to them, and really valuing the contribution that they made and giving back to them.
And I also want to add, Morgan, that it's not a good panel unless we have a cameo by pets or children or both. So thanks for bringing your kids into it. Kids are welcome all the time. So it makes for a better panel, makes it more real. So Wendy, I want to come back to you. I wanted to get your views on that. This, you know, the importance of quality of care as opposed to just medical care. How important is that to families?
Thank you, André. No, that's extremely important to families, because sometimes it gets just defined as in a checkbox as to what has to be ticked off to be done, as opposed to the actual whole care of, for that person, what they need, you know, that extra blanket, or, you know, just doing something a little bit extra, which would be just every day. But for something in long-term care, the way that it's been set up would just be another task for that person.
Yeah, we hear that. I hear that a lot from staff and from families, that they're just checking things off as opposed to listening to people or delivering, you know, doing what they want, which is often just have a cup of tea rather than something on the list that they don't really want.
Absolutely. And hopefully that can be able to change for the re-imaging of long-term care.
So let's talk about that. Let's use the rest of our time to talk about how to reimagine it and going forward. Doris, you know, we keep getting promises. Do you have more hope that things are actually going to change now, that we're going to get the standards of care, we're going to get the money to do it?
Oh, that sounds like the last question in the interview on Saturday live. The reporter, Dahlia Kurtz, who is amazing, I so desperate trying to help with her own with the radio, the goods, and she asked me, so has the premier given you anything after crying so much? Has he given you anything? And I'm sure she was hoping that I would say no, nothing. And I said, yes, he did give me one thing. He did give Areneo and people like Nathan and a few others that we pushed in different, together on the same direction, which was reuniting families. Let's remember, not every province has the ability at this point to bring the essential caregivers to the homes. We do, and that the onus is on the premier because he did help. So what I say with that, André, I never will lose hope, because if he could change his mind on that, I am hopeful, not that we will get all that we want next week, but at least move in the right direction. And the most important thing, André, and help us push that, is not if we will get right away the 4 hours or part of the 4, but that it be legislated. Because if not, we can kiss it goodbye, because after COVID, no one else will give that. And without those 4 hours, whether it's this amount of RN, this amount of RP, and this amount of PSW, it's important for someone like Morgan to actually create a good work environment, which Carole said is necessary, which makes a difference for residents. It's difficult to allow them the liberties that Carole speaks about. Allow them to, you don't want to bathe now, don't bathe now. You want to sleep a bit later, sleep a bit later. You want a toast with jam versus whatever. You know, if you don't have, like, I cannot picture, and I tip my hat to Morgan that in the midst of the pandemic, enter the sector. But picture the people trying to do most of the PSWs, André, most of the RNs and the RPNs and the almost non-NPs we have there want to do good care. They are people that go every day to work wanting to do good care. We just need to give them more so they can engage the families, engage the residents, have a life, focus more. Carole said it beautifully. Let's focus more on life versus how to prevent the risk that this and this and this may happen. And then we will have more fulfilled seniors, residents. Maybe they will die, you know, André, and that was our argument with the reuniting families. Maybe they will die a month before or 2 months before, I don't know. I bet you not. I bet you actually not, but they will be smiling till the end. We now don't give them that choice even. Carole said it, is we focus, look at inspections. We find what's wrong. I'm not saying we don't need inspections, but we focus on what's wrong. How about starting to focus? I said this to the Premier and Minister Fullerton. How about also focusing on what homes are doing right? So people want to work there, want to engage. And also ask the residents and the families, what is it they want? And Wendy gave perfect examples about that.
Now, Carole, you've been at this for a while. You said in your presentation, we don't need another inquiry. We don't need more reports. So how do we mobilize this collective action we're talking about tonight?
Well, I'm glad you left the easy question for me, André. I don't know the answer entirely. I think we have to break it down so people can understand what we mean when we say live with risk. It's one of the things we need to do. So let's think about falling. That's one of the most feared things in a nursing home. Falls aren't really the culprit. It's falls that cause injuries like broken hips, which are catastrophic. We could put compliant flooring in all our nursing homes, and yes, it would cost some money, but it would reduce injuries. We could have programs where people, where there was work on people's mobility and gait, so that would prevent falls. We could put the right kind of assistance in the environment to reduce falls. We could work, and I know there are people in the country who do work with it, with places like AgeWell and the Toronto Rehab Institute on technologies. But we have to stop doing it like pilot projects. You know, if I go to one more meeting where we say, oh, Canada's a land of pilot projects and it's going to be the end of us. Well, we need to stop and we need to start taking things to scale. And so what I'm trying to say is we need to make it concrete for people, some of the things we have to do. In terms of how we get to action, I do think that the premiers and the federal government are going to have to do some mobilization if they can get past the jurisdictional bickering that's inevitably going to occur. But I think, you know, Canadians who are over 65 are an enormous voting bloc. And we need to be able to mobilize that bloc the way we've mobilized other groups, with the same kind of power and impact that we mobilize the movement around Black Lives Matter. I mean, it has to be on that order of magnitude to get sustained change over time. It's not going to happen overnight. We can't fix this in a day. We can start with fixing the workforce and then spread out from there, but we have to rethink what we're doing. We can't just build a better mousetrap. We've got to say we don't want mousetraps anymore. We want to vision it differently so that we can live differently as we age. And so I don't have a good answer. I'm just talking around different things I think we need to do. But I think we just, like, we know what to do. And those of us in the field who've been here a long time could just poke our eyes out. We're so frustrated that the mobilization part is where we've really struggled. And it really comes down at the end of the day of are Canadians going to make a choice for it to be different? And are we going to do the things that need to be done to demand that the appropriate levels of government listen? And are the professional schools going to do something? Sorry, Doris, I just want to put one plug in for, nursing doesn't have anything to necessarily stand up here and have a parade about. We are not doing the things we need to do, and medicine has the same issues and other disciplines too, to promote this as a noble profession, as something we need to do. I don't know why every dean in the country hasn't hung a shingle out and said, we're the center of excellence for aging.
So André, you asked before if I have hope about next week. And the reason I wanted Robin to speak is because Robin is one of the many seniors that came to RNO with issues about not being able to visit her loved one. And we actually took Robin and a couple of other family members to the premier like that, in the phone. In the middle of a call, I called the premier, and one of the senior staff came in and was willing to listen, and they actually took on the issue, and then they helped. So she deserves tons of credit for pushing for family reunification, and the premier, to his credit, did help on this issue, and that's why next week we have some hope. Robin, thank you. Actually, Robin, is the first time that I see you virtual. Before has been only by phone or by email.
Okay, well, I didn't do my hair.
Well, you look fantastic.
Thanks. Thanks, Doris, and thank you for everything that you've been doing for months on end, for years actually, and how you put yourself out there for all family caregivers is just like, it means a lot to everybody. So thank you.
You share your story, please.
Oh, I think probably everybody knows my story, but yeah, I mean, I think my biggest thing right now, and that I'm going to keep fighting for, is that long-term care homes are institutions that are not, they're so broken. I don't think they can be fixed. I think that, coming at this from just 8.5 months ago, being completely oblivious to all the problems before that. My mom lived with me for 3.5 years after her first and second strokes. And, when I got caregiver burnout, the only option was a long-term care home. And I thought I was putting her into a 5-star resort based on the website. I felt bad she wouldn't be around her family and her dog, but I just couldn't do it anymore. And the doctor changed her medication upon arrival, and her blood thickness was like up and down like crazy, and her sugars weren't being dealt with. They were in the high teens and 20. The nurses were reporting it, and nothing was changed. No insulin changed. She had her third stroke within 3.5 months of entering. She went in there walking and talking and eating, and within 3.5 months, third stroke, debilitating, 100% dependent on everything. 30 days in the hospital, they told us she had to go or she would lose her bed. She hadn't gotten over the shock yet to pass a swallow test. So she got a G-tube, and my sister and I were spending 10 hours a day in the home, helping, being part of the care team. That was December 2nd, 2019. And so 3 months later, we're locked out, no exceptions, and wouldn't let us even have a camera in there to be her call bell. you know, talk to her when she was awake, be involved in her day-to-day care. So I got mad early on because, you know, what's the problem with not allowing a camera in so that I could stay out yet stay involved in her care? So, you know, I have watched, like I went to social media at the beginning of May, and I started ranting nonstop, 16 hours a day in near the beginning of May. And I have kind of watched other people about 2 months behind me getting mad about the things that I was mad at 2 months earlier. So I'm really concerned about all of this. My mom went to the emergency room 4 times in 11 months of being in long-term care. 2 of those 4 times during the lockdown. She didn't get treated for early congestive heart failure. I saw this on Skype calls. We forced her to the hospital. The ER doctor did a great job, treated her, but sent her back same day, and with a treatment script for 14 days of Lasix and follow-up blood work. And then she had so she has a suction machine by her bedside. So we were suctioning her throughout the day as needed, and I don't think it was getting done. So when she was deep suction, they would swab her for COVID when there was no COVID in the home, and locked her in a room for 10 days without TV. First time, and the second time 8 days. And I think part of that might've been retaliation, because I advocated very strongly. That just makes me mad. Every day for 4.5 months, I went to a window for 2 hours a day. And I saw a lot of things that went on that were not very good. When she came out of the first 10 days, she was jolting. After I researched, I found out that that's a sign of one of the last stages of, like, they're falling off a cliff. And there's nothing you could do on the other side of a window. So the second time she went to ER, I guess she'd thrown up 3 days, and they phoned my sister on that one once. And on a Skype call, I saw that she had a very phlegmy mouth and called the nurse to give her some oral care. But then I went to the window the one night, and the doctor was outside talking to my sister, saying she'd refused oral care. And so he thought she'd given up her will to live, and recommended pulling her feed for a couple of days to see if she made a fuss. My sister said, well, she's diabetic, she will bottom out. And he said, well, let's pull 2 of our 4 feeds. So I got very upset about that. Made another big fuss. I think I even posted that on Twitter, and watched it roll all night long with impressions. The next day I got called from the home to get me, and I was allowed to go in. And, you know, this was June, this was unheard of, but I was allowed to go in for 2 hours a day for a week to see if she perked up. And I'm pretty sure that's because I'm pretty active on social media. So, that night, I went there the next day, and then that night she threw up again. And the brand new night nurse, who had just gotten her diploma from Trent University, just took on the night shift job, I guess didn't know the rules that you don't send them to the hospital. When my mom threw up in the middle of the night, she phoned my sister and said she thought my mom should go to the hospital. So she was admitted for dehydration. And then I started to fight with the hospital to not discharge her. And they threatened me to charge me $1,200 a day if I didn't send her back. So I finally just decided enough was enough, and I brought her home. And she is definitely a 24-hour care needs. 7 days a week. So I'm here, and I'm doing the best job I can. And it's been 4 months, and she is stable, but certainly not where she was at March 15th. I feel she's been robbed time. And the reason why I'm not giving up is that I feel for all the other seniors that I watch through the window who are my friends, you know, spending so much time there. And so I'm really, I think institutions have to go. They have to go. They, you know, I think for me, the quickest thing to solve this problem with $1.75 billion would have been to buy up a bunch of condos and small homes in the community and, you know, empty them 4 to 8 at a time, you know, and get that greenhouse project type model going, where it deals with so many of the things that you're talking about here with the quality of care. And I think it would bring back PSWs into the field naturally. And the PSWs that now rotate through my house on a daily basis, when I chat with them about it, because so many of them refuse to work in long-term care. It's not humane care, so they will do home care, but they don't want to work in long-term care. But when I describe doing, you know, cooking and laundry and engagement activities, as well as the personal care, they're like, yeah, in a heartbeat, I would go do that. So, you know, we've lost a lot of PSWs that are certified because of the situation, that don't want to go back into the field. But if we had these small care homes in the community, I think that we would be bringing them back naturally, and we could, you know, it would bring more into the field as well. Because the people that
I want to thank you, Robin. We're almost
Okay.
out of time. I want to thank you for sharing your story with us. I just want to give each of the panelists a last minute to send us home with a hopeful message. And these stories are not always uplifting, so I always like to end with something a little bit hopeful. So I wondered, I'll start with you, Morgan. What gives you hope going forward? Do you think we'll fix this? I'll start with you, Morgan, if I could.
My hope going forward is that we do see a significant announcement soon about funding in long-term care homes and a specific skill mix ratio to help. I know there's a lot of work that needs to happen in long-term care. I have many, many hopes for long-term care, but I think one of the first steps to making it better for residents is to increase the funding, but to use that increased funding to increase staffing in long-term care.
Great. And Wendy, as a family member, are you hopeful that things are going to change? What gives you hope going forward?
What gives me hope going forward is that all family members are talking. They're talking that things do need to change. It cannot stay the same as the way that it is. And, you know, we're assisting with that in terms of what we're talking about, what we're discussing. And at least this is a good initiative. And it's more for, hopefully, you know, with what Morgan is doing as administrators, more administrators change their line of thinking as well, because that is the key in any type of long-term care facility, whether it's municipally run, whether it's for-profit, not-for-profit. The administrator has the key as to how to really direct the ship in each facility. So as long as we can try to affect change and see more of the positivity of what Morgan is doing, then that would be great.
Yeah, the family speaking out is hopeful. If we start listening to you, it'll be even more hopeful, I think. So, Carole, do you have a hopeful message going forward?
Yeah, I'm hopeful because there are solutions. This is fixable. This is not like trying to find the cure for cancer. This is so fixable. And I do in my heart of heart believe that Canadians don't want, they want us to do better. They want to do better. And that there's will there if we can mobilize it to help us implement the solutions.
Great. Yeah, good message it is. We all know all the solutions. We just have to implement them. Nathan, you're always a hopeful person. How can you send us home with some hope?
Look, you know, I think we started the pandemic forgetting about the sector, as it has been forgotten about for decades. And the sector experienced the brunt of the pandemic in ways that should never have happened. You know, today, although, I led off by saying I don't want to let vaccine euphoria get in the way of, the work that still needs to be done. We really should reflect that, in a country like Canada, how remarkable it is that we put at the front of the line of, what is perhaps the most precious commodity of 2020, an older adult in Quebec to receive the first vaccine in Canada, and a personal support worker in Ontario who has worked in long-term care homes. And I think that shows that there has been a shift in care and focus on this sector. We can't let it stop there, but that really gives me hope. I was working at Mount Sinai today, and just right near me, the UHN distribution site was giving that vaccine around noon. It honestly brought tears to my eyes to watch that personal support worker and to think about how, it's not usual. I think Louise Aronson, who's one of my favorite geriatricians and writers, wrote that it's not usual to put bus drivers before bankers. It's also not usual to put personal support workers before doctors and other wealthy people in society. And I think that was really remarkable and gives me hope that the narrative is changing in the sector.
Wonderful. And Doris, the last word to you. Give us something really hopeful.
Absolutely, always. And I want to always keep here the story of Robin Nelson and the many Robin Nelsons in the world, so that we never give up. And I want for Canadians to make this, through these national standards, a political fight for every platform, whether it's national or provincial, so that actually for once we actually move to better solutions, because the people that build this country deserve nothing less.
Great, a wonderful note to end on. Let's create an elder care system that's worthy of our elders, I think is a really good message for the whole panel to send us home with. So I want to thank everyone on the panel for joining us tonight. Nathan Stahl, Carole Estabrooks, Morgan Hofath, Wendy Francis, and of course, Doris Grinspan. And I want to thank mostly the audience for joining us tonight. A large number of you stayed here right till the bitter end, even though these are long days, long pandemic days. So I want to again, thank you for being there. Best wishes for the holidays for everyone, and please stay safe, and hopefully we'll all experience some vaccine euphoria really soon. So thank you and good night.
Thank you, André. Thank you to you.
Thank you.
Thank you. And thank you to the panelists.